staff are in listen-only mode.
Hello, my name is Mary Bennett, and I'm a community coach with County Health Rankings and Roadmaps program, and I'm joined by my colleague, Erica Burrows-Girardi.
Hello.
Erica will be helping to answer your questions as well as sending some links out via the chat box during the webinar. And we're very excited today to have with us Tracy McClendon Cole, Deputy Director of the Health Department for the City of Kansas City, Missouri, and Rashid Janae, also part of the Kansas City Health Department, as a Violence Prevention Manager with AIM for Peace. We also have Shannon Cosgrove, Director of Health Policy for Cure Violence, and she is based in Baltimore, Maryland. This exceptional team will be sharing the model of their work and its application to reduce violence in Kansas City, Missouri. We're grateful that you're joining us today on this timely and critical topic. So welcome, Tracy, Shannon, and Rashid.
Hey.
Thank you.
All right, so first we'd like to acknowledge the important relationship we have with the Robert Wood Johnson Foundation. County Health Rankings and Roadmaps is a collaboration between the Robert Wood Johnson Foundation and the University of Wisconsin Population Health Institute. Next, we want to make sure that you get oriented to the technology we're using today. The GoToWebinar attendee interface is made up of two parts. On the left, you can see the viewer window where you'll see our screen throughout the presentation. On the right, you can see the control panel. You can also interact with us through the control panel by using the questions section. Please feel free to ask questions or share your thoughts and experiences with us via the control panel throughout the webinar today. And we'll be sure to leave time for questions because I know that many people have commented on that they'd like to dialogue with the presenters. So this question guides our webinar today. So as you listen to the webinar, please reflect on what strategies might you consider implementing in your community to reduce violence and its negative impact on health. We're going to start with a brief program overview to ground our discussion in the County Health Rankings and Roadmaps, and this will take just a few minutes. If you're newer to us, this will give you a high-level overview of County Health Rankings and Roadmaps. To learn more, we encourage you to check out one of our Rankings and Roadmaps 101 webinars. Erica will chat out a link to our most recent recording. So County Health Rankings ranks the health of nearly every county in every state in the United States annually. For each county, you'll find two rankings, one for health outcomes and one for health factors. This image shows the relationship between policy, health factors, and health outcomes. It illustrates why it's so important for communities to take a broad definition of health. The rankings make it clear that good health includes many factors beyond medical care, including education, housing, community safety, and much more. It shows us that all these factors impact how well and how long we live. So starting from the bottom, we know that effective local, state, and federal policies and programs can improve a variety of the health factors that in turn shape the health of the communities. So for health factors, we specifically look at health behaviors, clinical care, social and economic factors, and the physical environment. So today's webinar focuses on violence reduction, which spans many health factors, but specifically community safety, and we'll hear from our guests about their impressive work in Kansas City. So why is violence reduction important? High levels of violent crime compromise physical safety, psychological well-being. Additionally, exposed to crime and violence and has been shown to increase stress, which may exacerbate hypertension and other stress-related disorders and may contribute to obesity prevalence. Exposure to chronic stress also contributes to the increased prevalence of certain illnesses such as upper respiratory illness and asthma in neighborhoods with high levels of violence. High crime rates can also deter or prevent residents from pursuing healthy behaviors such as exercising outdoors. So our guests are going to talk a lot about this in a minute. But taking a closer look at what we measure for violent crimes in the county health rankings, here you see an example of the county snapshot, the summary of the data for Jackson County, Missouri, noting that Kansas City spans 4 counties, Jackson, Clay, Platte, and Cass, and here we've highlighted violent crimes. The violent crime is the number of violent crimes reported per 100,000 population. Violent crimes are defined as offenses that involve face-to-face confrontation between the victim and perpetrator, including homicide, forcible rape, robbery, and aggravated assault. So moving from data to action, we turn to the roadmap's Take Action cycle, which is an important part of how within the county health rankings and roadmaps, or how to, I should say. The Take Action cycle lays out a series of steps that communities can take to create healthier places to live, learn, work, and play. Here you'll find a series of guides, resources, and tools that support communities in each step. Assessing needs and resources, focusing on what's important, choosing effective policies and programs, acting on what's important, and evaluating actions, all encircled by work together and communicate. At the core of this model are people working together to improve health in a community. Health is everyone's business, and we believe people from multiple sectors have a role to play in improving a community's health. And our guests today, as part of their presentation, are going to share how they've worked with diverse stakeholders to transform their community. One of the key tools in roadmaps is What Works for Health, which provides an easy-to-use, searchable menu to help you select and implement evidence-informed policies, programs, and systems changes for the specific problem you are addressing. It includes evidence ratings, literature summaries, and implementation resources with over 400 strategies. Here you see the search for violence reduction will cure with the Cure Violence model and many others listed. In addition to our online resources, we have 11 community coaches who provide customized consultation to local leaders who have requested guidance in how to accelerate their efforts to improve health. Thanks to the support of the Robert Wood Johnson Foundation, this assistance is available at no cost to you and your community. Community coaches provide community leaders with direct support to strengthen their capacity, your capacity, to advance health improvement efforts in your community. This support might be one phone call or email, may be short-term, or it can be long-term coaching up to 12 months. You'll see these orange boxes located throughout the Action Center, inviting you to connect with our coaches, such as Erica and myself, if you need assistance with a tool, a question, figuring out the next step in your process, or building the collective capacity of your coalition or community to accomplish goals. I'd like to also highlight the Robert Wood Johnson Foundation Culture of Health Prize, which honors communities whose efforts illustrate an enduring commitment toward creating a culture of health for all residents. Winning communities receive $25,000 cash prize and have their success stories celebrated and shared broadly to inspire locally driven change across the nation. The 6 criteria displayed on the slide drive the selection of prize winners. Our guests today from Kansas City are Robert Wood Johnson Prize winners, and they were honored in 2015, and their work continues to be recognized. So it's my pleasure to introduce you to our special guest presenters today. Tracy McClendon Cole is the second female and the first African-American Deputy Director of Health for the City of Kansas City Health Department. McClendon Cole has more than 15 years of experience in private, nonprofit, and public sector management and program development with an expertise in fiscal, legal, and policy analysis. She's responsible for overseeing regulatory programs for a large metropolitan health department, planning and coordinating department administrative activities, working with department managers that direct over 158 employees in a number of health-related professional disciplines, including public affairs, disease prevention, environmental, and education, in addition to monitoring legislative activities affecting all public health programs. She works to enhance the department's ability to address cultural diversity, health disparities in minority communities, and the economic impact of reduced public health funding, as well as continuing to foster violence prevention efforts and improve departmental relationships with community and civic partners. Shannon Cosgrove serves as the Director of Health Policy at Cure Violence, where she is responsible for defining and promoting the health approach to violence prevention. Her projects include assisting with the National Health Collaborative, identifying policy priorities, promoting community healing, building partnerships, and ensuring equity is embedded in the work. Previously, Shannon served as the Deputy Director for the Mayor's Office on Criminal Justice in Baltimore City. Her past roles include Health Equity Manager on the Healthier Community teams at the YMC of the USA, Project Officer on the Centers for Disease Control and Prevention's Racial Ethic Approaches to Community Health team, and Health Disparities Coordinator at the Baltimore City Health Department through the Centers for Disease Control and Prevention Fellowship Program. Shannon served as a peer behavioral interventionist at the Grant Coordinator at the Center for Volunteers in Medicine while receiving her MHA and BSc from Pennsylvania State University. We also, last but not least, have Rashid Janae, also of the City of Kansas City Health Department, and he's worked to transform the mindset and criminal behavior patterns of high-risk people for over 10 years. He's been working with the Aim for Peace program for the last 8 years and is currently a violence prevention manager. Rashid manages the operations of the neighborhood outreach team that's responsible for mediating violence and potential violent conflicts, as well as case management of high-risk individuals in the community. So again, welcome Tracy, Shannon, and Rashid. So Shannon, could you please start us off by talking about why is it important to take a health approach to violence prevention?
Sure. Good afternoon, Mary. It's an honor to speak with you and other leaders on the call who are committed to improving the health of our nation. At Cure Violence, we're an NGO in over 64 communities across the United States, including in Kansas City, which you'll hear about later. We see violence as a health issue and use a public health model to reduce violence and its subsequent trauma. And since 2000, we have stopped thousands of shootings and killings, including upwards of 70% reduction in historically violent areas. We know our program works, as do many other health approaches, so we are excited to talk with you all to work with us to shift the thinking towards violence as a health issue and to help shift resources so we can begin implementing these approaches to save lives. So why is violence a health issue? Well, health, as you see here, is a complete state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. So when violence is present, health cannot be. When Dr. Sluckin, the founder of Cure Violence, came back from Africa after working in refugee camps with thousands of people experiencing cholera, TB, and HIV with only 7 doctors, they were able to curtail the spread of these contagious epidemics. And when he went back to Chicago, he saw that violence was looking the same as the maps he saw in Uganda. It's behaving like an epidemic. Clusters in neighborhoods and transmits from person to person through exposure, spreading like the flu with an added layer of modeling between generations, between communities, and even in conflict zones. We see the spread of all forms of violence. So it is very much true that violence begets violence. It impacts our health directly through physical and mental wounds and is associated with many chronic diseases, as you just stated, Mary, such as heart disease, stroke, and cancer. It also impacts every social determinant of health, which Tracy will get into. So you know that when violence is present, educational attainment decreases, housing quality decreases, economic investment is lacking. So it is, by all definition, a health issue. And it is affecting some communities more than others, specifically our communities of color, and at alarming rates. As you know, we in the health field have made major efforts in reducing health inequities. And so you could see many health inequities listed here, and these are the ultimate mortality rates and the differences between the black population and the white population starting in 1985 and then fast forwarding 30 years to where we are today. And you can see how the changes have happened over the years, and I'm sure you all know of the investments and the work that have gone into these various issues. But as you can see, there's only 2 that have actually gone the wrong direction. So cardiovascular disease from 20 to 30%, so 50% growth, versus homicide actually started out with 400% difference and now is at 470%. So we are going the wrong direction. And we must do something, and we know that there are solutions available, and fortunately we are seeing progress in many pockets nationwide. Mary, are you on mute?
Yeah, thank you. So what are leaders across the country doing to address violence, and who are some of the leaders and key partners in this movement?
Right, so as you can see in this map here, leaders across the country are using a health approach to violence in various forms. And so we've mapped out who our partners are and who we know are using health approaches. And these are just local sites. So if we were to map out our national partners, this map would be covered. But again, that's not to say that, you know, we've got it down and that the health approach is being implemented everywhere. It's happening in pockets instead of what we want to really talk about, which is a comprehensive approach. So what we are seeing, and we're very, excited about, is, in San Francisco, where crisis response to violent scenes are part of protocol. Over 8,000 people within their health department have been trained in trauma response and trauma-informed care. Or hospital-based violence intervention programs, as in the Boston VIAP program, or screenings for violence-related trauma in schools with curriculum for middle schoolers who are specifically at risk for violence in Chicago. and then multi-sector comprehensive initiatives, which have some focus specifically on safe parks and public spaces like in Minneapolis. So we're working to join forces with all these experts, all these individuals that are doing this great work across the country. And we have leadership from Dr. David Satcher, the former Surgeon General, Dr. Al Summer, the former Dean of the School of Public Health at Johns Hopkins, and Dr. Gary Sluckin, the CEO and founder of Cure Violence. And we're working with over 35 health departments as well as many national organizations, including NACCHO, including Common Health Action, NAACP, National Health Equity Coalition, Urban League, and others. So there are many partners and there are many people who are in this space, but what we need to do is build out a more comprehensive, robust plan. And unfortunately, there is more than enough work to go around, and there is space for us all to partner on this.
And this is an impressive list of leaders and a map of communities and network. So why is it important to build this as a movement? And how do we need to change how we think about violence to begin to address its negative impact?
Yeah, so this is fundamental. I think we could all think about the news. We could think about common talk between people, whether it's in our office or in our community. We could think about a lot of the policies even, and how specifically violence is about punishment, and violence is about bad people and bad places and bad communities. And instead, we know that there are health approaches that are working, and that violence can be not only interrupted, but it can be prevented, and we could ultimately heal from this. And we as health leaders have been too silent in this space. You know, I just showed that last chart, and it is a significant difference in what we have done in terms of cardiovascular disease versus what we've done in violence. So we can do more. And we believe that we will see a reduction in racial biases, we will see a reduction in inequitable treatment, and we will see a reduction in criminalizing of entire communities. The health approach also allows for that reduction in system-based trauma, so how to not make the situation worse for individuals who are already dealing with violent situations through our systems. And it will open up opportunities for funding and for this approach to be put into play. So it's really a paradigm shift that needs to happen, and we need to think about things differently, talk about them differently, and then that needs to be followed by action.
So talking about this further shift of our thinking, and can you talk about what do we need to do to deepen our understanding to reduce the current inequities?
Yeah, a huge component of this shift is how we see people, like I said, but it's also in our system. So gunshot victims are often not given proper pain medication because of assumptions that are made in terms of them chasing meds, or that they have a high pain tolerance. Or domestic violence victims are often blamed for staying in unhealthy relationships, or even thinking about how we as a country have dealt with police-involved shootings of unarmed Black people, what story is told, and how are individuals criminalized even before the full story is told. So this moralism needs to change, and we really need to again start thinking about moving away from punishment and blame, and more thinking about contagion and exposure. And so here you see that many are showing up to make this case.
Yeah, and can you give, here's some examples of where it's a more positive spin, right? Or a spin of concern in terms of how the narrative on gun violence.
Exactly. So you'll see articles here from Dr. Mary Bassett from New York City, Dr. Lena Wen from Baltimore City, Sanjay Gupta from CNN, and Hillary Clinton has even talked about violence as an epidemic. And so you'll see that this narrative shift is starting to change, and as we see health experts, and they are seen as experts in terms of violence, this mindset starts to shift, and the idea that there is a different way comes to bear. So we need more of that, and we need health experts to be more present in words and in actions. And what Dr. Sluckin says here often is that we have misdiagnosed this issue, and the health field needs to play a bigger role in healing this epidemic.
And also, Shannon, can you please share with our audience what the long-term vision of the is of the movement?
Yeah, so we believe that violence can ultimately be reduced by 70%, which sounds drastic, but given the numbers of cure violence, which you'll hear from Tracy and Rashid, but also from our partners, we're partnering with people who are experts in reducing violence of all forms. So if we were to completely redo our system of how we prevent and intervene against violence, we believe we could see a significant reduction. And Kansas City is making major strides to see this as a reality. We are excited at the idea of this reality happening nationwide.
So thank you so much, Shannon, for sharing this information, for your work and that of Cure Violence. And now it's my pleasure to turn to Tracy and to Rashid and their exceptional work addressing violence in Kansas City. So Tracy, please first give our audience some background on Kansas City, its challenges, and how you began this journey of working with the community, taking leadership as the health department to reduce violence and develop AIM for Peace.
Thank you, Mary, for the opportunity to share about our city's public health approach to violence prevention. The City of Kansas City, Missouri Health Department is an accredited health department by the Public Health Accreditation Board, or FAB. We've been awarded 6 model practices and 6 promising practice awards by NACCHO, which is the National Association of City and County Health Organizations, recognized for our enduring commitment to traditional and innovation approaches to health for all residents. KC Health Department is also a 2015 Robert Wood Johnson Foundation's Culture of Health Award, as you acknowledged, Mary, as well as a 2016 NACCHO Public Health Department of the Year awardee. Throughout our rich 150-year history, KCMO has encountered many different challenges as it relates to past practices of segregation, creating a physical or cultural gap between communities, and then also created a sizable concentration of racial and ethnic underserved populations or populations of color that have been racially and socially economically divided. The poverty rate in Kansas City for African Americans is 22.5% and quite centralized in terms of our urban center or our urban core. Well, the white poverty rate, or the Caucasian rate, is about 5.8% and spread geographically throughout the city. Nearly 29% of African Americans and Hispanic Latinos live below the poverty level in our Kansas City, compared to less than 18% for all other residents. And specifically in Kansas City, we know that the threat and the use of violence specifically and significantly impacts the way that members of a community socially interact. So in order to retain our businesses as well as to retain our residents, we had to create pathways to prevent further urban flight and community violence. And we knew that ultimately we had to work toward curing violence.
So how does Kansas City fit into, we were starting with the County Health Rankings and Roadmaps model, and how does it fit into the understanding of the many factors that influence health?
Kansas City is a very unique community in that we sit on a borderline of 2 different states, and as the heart of the Midwest. Essentially, if you look at the map of the United States, we're smack dab in the middle, so we're the heart of this country, but we're ranked about 37th most populated. However, when you look at the social and economic factors in terms of our 4 counties that we sit in, Jackson County being the largest county and a good proxy for our city, is about 95th out of 112th in terms of social and economic factors on the county, the current county health rankings. However, one of the things that we know about our social and economic factors is that they're greatly impacted by population health. What we look at in terms of community safety as it relates to community violence, especially retaliatory violence, is that this has been an ongoing issue. It's not something that's new, but it's a historical issue that has disproportionately impacted Kansas City's urban communities of color. We know that violence sustains health and economic disparities in our communities in terms of racial disparities, income inequalities or inequities, segregation, housing, education, and so on. But there's a cycle that keeps people stuck in health and social and economic disparities. We know in Kansas City that we can break this through a positive framework, a public health framework.
Thank you. And further building on this framework, how do we need to address social inequities to achieve health equity and gain a deeper understanding of this interrelationship of issues?
In Kansas City, specifically looking at the Aim for Peace, Cure Violence method, what we wanted to do was focus our attention on the social determinants of health as they relate to health and economic and social factors that influence health. So we know that everyone's sector or everyone's concern is more than just believing that we have to stop thinking of health as something as we just go to the doctor and get cured for that, but instead of something that starts in terms of our families. How do we actually improve our health in our homes, in our schools, in our workplaces, in our places of worship, in the air that we breathe, the water that we drink, and so on and so forth. The more that we begin to change to see problems of health impacting this way, the greater it is for us to overcome the determinants of health that lead to social inequities. We know that we have to expand the way that we think about health so that we can actually begin to get our health back.
And looking at the county health ranking snapshot of Jackson County's health, you talk about what you see as important to note and how the factors in violence have had that direct impact on life expectancy.
Violence in Jackson County is literally making us sick. We know that through decades of research that exposure to violence, especially during childhood, adolescence, and young adulthood, it contributes to poor mental and physical health, trauma, unemployment, graduation, and lower life expectancy and outcomes and lifespans. However, in addition to those things, they also include some of the aspects that you spoke about earlier, Mary, as well as Shannon alluded to, about behaviors that actually increase the risk for smoking, overeating, illicit drug use, depression, anxiety, and the chronic diseases. But however, it is preventable.
Yes. And so in your work to address violence and its impact, and you talk about the theoretical shift that needs to happen so that everyone has the opportunity for optimal health.
Yes, we know that science is evolving, but it's extremely hard to address every single social, academic, ecological, physiological issue, especially when violence is still present in our communities, because it inhibits the ability to adequately resolve these underlying factors. In public health, we know that we can find workable solutions through our public health framework so that all have an opportunity for optimal health.
Excellent. And I know our participants are eager to hear more of the specifics about the Aim for Peace program. But first, can you share kind of an overview of how you're using the model?
Sure. The Aim for Peace Cure Violence Health approach or public health approach uses the same epidemic control methods to stop the transmission of some of the most deadly infectious diseases, including AIDS, cholera, and tuberculosis. Ultimately, what we know in terms of this framework is that we have to begin to interrupt the transmission of the disease, change the behavior of those at the highest risk for violence or whatever happens in terms of looking at ultimately getting to changing community norms. In Kansas City, we knew that we needed a new public health worker and a new innovative practice within our city to change norms within the governmental system to be able to affect the outside system. Ultimately, we had to work with our legal department, our human resources, risk management, and legislative oversight to be the first department to actually hire, transform returning citizens or ex-offenders who were formerly mirroring the acts of violence that were happening in the environment, to actually use them as community health workers who are now in our city's classification system to actually reduce the level of violence.
This is impressive. And so now turning to you, Rashid, as you are the public health worker in the community, can you talk about more your work with Aim for Peace?
Aim for Peace treats persons ages between the 16 and 40 who are at high risk of perpetuating retaliating violence in their families in the East Patrol. So we're working with the individual and the family. Home to like 90,000 citizens. There are roughly 25 known active gangs in the Aim for Peace zone who make up roughly 1% of the target zone population. Group members range as young as 12 years old as well as 49 years old. Approximately 95% of the group members in the area are male. Aim for Peace promotes life, preserves the community by providing necessary services to help change negative behaviors and social norms and protects the health of each resident in the community. Through a combination of shooting data and street knowledge, we identify hotspots and focus on individuals at the highest risk of being involved in shooting.
And how is Aim for Peace using this theory of detection, interruption, changing the individual behavior norms of those at highest risk of transmission, and finally shifting the norms in the community to prevent this further spread?
We understand that violence causes violence, so violence is caused through witnessing and copying. You see violence, you do violence. We wonder why some people who are child molesters then grow up to be suffer child molestation and grow up to be child molesters. It's the same thing with violence. They suffer child abuse and some trauma as they continuous trauma as they're young, and then they become violent. And so this is how violence is transmitted. And we have a little slide here. We talk about the amygdala. It lights up when you become angry, and your frontal lobe tells you, chill out, calm down. So if you were at work, you become angry, and say, I'm going to quit this job today. Your frontal lobe would say, don't do that. You got bills to pay. You got kids to feed and things like that. But somebody who experienced a high rate of trauma in their life, they're like, the hell with this job. I'm out of here. You know, and slam everything down, knock everything off this, and they're out of there. So this is where the street intervention worker and all of the methods that we employ come into play.
And could you talk more about kind of the thinking behind creating new social norms and those shifting those expectations?
And so we believe that the higher the exposure to violence, the more that you're going to do violence. The lesser the exposure to violence, the less that there's possibility that you're going to do violence. And so if all of the people around you, this group immunity that we're showing, that actually, if the peer pressure that is around you, the people around you saying, don't do this, don't do that, so that gives them an example of what to do. So your brain is hardwired to do this. So if somebody starts doing the nay-nay, you start doing the nay. Somebody starts laughing, you start laughing. If somebody wants to fight, you want to fight. And so this modeling and copying is a part of the culture that we see that's going on, and we have to create this group immunity through interruption and modeling different practices.
And in your work to create these new social expectations to achieve group immunity from learned violence, what are the various components of the program, and what partnerships have been key to your success, and who have you engaged?
We have key partnerships in the community leaders, community business people, residents who become our points of contact. Sometimes they're the first people to call. They call us when something's going on. We have a peace line that they can call. Kansas City Police Department, they call us when they have a situation they can't arrest out of. They call Aim for Peace, say, hey, we have 100 bullet holes in this house, 100 bullet holes in this house. Nobody wants to cooperate. Aim for Peace needs to get in there. And so we have a case management component to that, where we're doing case management with high-risk people, leading them to a more responsible living lifestyle, working with them through their life domain areas, and all of this serves to change the community norms and the community behavior. So you have that person who's the highest risk now modeling a behavior of responsible living, so everybody that were following him at first, now they're following the good that he's doing. So we've seen that effect happen with these young people.
Wow, very impressive. So I just want to express my deep appreciation for your work, and I know we've commented on several significant awards and recognition and visibility, but can you talk about these a little bit more, because I think it is so important for others to know about your work and also how people are recognizing its value.
In 2011, Aim for Peace received a NACCHO Promising Practice Award. In 2016, we won the NACCHO Model Practice Award. Other awards include, in 2016, the Missouri Department of Correction, Probation, and Parole Division's Community Partnership for Safer Communities Award, received the distinguished honor of being awarded the Group Merit Award by the Missouri Public Health Association. In addition, Aim for Peace has received visibility such as an in-depth article by the U.S. News and World Report on the Aim for Peace Hospital Response Program in partnership with Truman Medical Center to prevent violence.
Excellent. And before we go to the questions from our participants, can you talk about what's the next evolution of your work? And I think that Erica's going to chat out your brochure so people have that full picture of the work.
The next evolution in terms of what we're looking at in Kansas City with the Aim for Peace program and as a public health framework to violence prevention is really looking at how can we bring together more and enhance more community partnerships to support violence and injury prevention. In our area, we know that specifically looking at how we can affect those social, economic, and determinants of health can actually help us, as well as increasing access and understanding and resiliency factors toward trauma. And so that's the next wave of where we'll be going in Kansas City to begin to create a greater population and culture of health.
Well, thank you so much for your work and your innovation at really addressing this head on. And now let's see if we can answer some of the audience's questions, and I'll turn it over to you, Erica.
Thank you, Mary. This is Erica, and thank you so much, Shannon, Tracy, and Rashid for that overview of the great work you're doing to address violence. And we've had a number of questions to come in. I'm also encouraging you all of our listeners and participants, please do chat in additional questions. Use the question box to do that. I want to get started with a couple of questions that have come in. And Tracy, I think this first one might be more appropriate for you. The question is, what are some strategies and tools that can be incorporated into health improvement plans, such as a community health improvement plan, a CHIP? And can you just share some of those strategies and tools for our audience? Thanks.
Absolutely. I am very excited that actually one of the foremost leaders in the health field is actually embracing a concept called Public Health 3.0. And this is something that I think in terms of community health improvement plans for health and health workers and health leaders, we have to really look at what is the next context for us in terms of addressing not only the situation or solutions to violence, but also in terms of the social determinants of health as an overall piece. One of the primary strategies that we have to do is enhance the leadership of our entire workforce as a public health field. I think one of the things that we have done in public health is to really look at ourselves as somewhat the director or governmental agency, but what we need to start looking at ourselves more broadly as like the chief health strategist in our communities and actually mobilizing other sectors, including like our business sector, our media sectors, our public works sectors, of how we are actually creating action plans to affect health through our CHIPs. One of the things also that we can also do is look beyond those new partners and how those multiple sectors come into play by also developing timely and locally relevant health information systems. One of the things that in public health, if you go to some of our data sets, we often have outdated or merged information over several years, but we need to begin to create actionable level data that can be produced at the neighborhood level as well as at the overall population level to begin to affect technology and using that technology as a tool to include new ways for us to measure our success. Because one of the things that we know CHIPs are supposed to do is to help us to identify what constitutes a healthy and sustainable and thriving community. Thus, we need to be able to measure it effectively and appropriately so that our residents as well as our legislative and policy folks can have greater information and understanding so that they can ultimately, and this is the last thing I promise, help us with funding. Because one of the things in terms of health is that we oftentimes are the people who are doing the work, but we don't always promote our work to the point where it's understood and recognized in the larger community. And I think through our CHIPs, we have an opportunity to go out and be policy advocates through our community health improvement boards, through our community health improvement plans, to actually push our federal governments, our state governments, our local governments to expand for new and other forms of financial support for public health to support activities that actually impact, evidence-based activities that impact the social determinants of health, such as violence prevention or like the Cure Violence model and many other factors that relate to it.
Tracy, I love the way you say that, you know, our community health improvement plans, our CHIPs, and our local communities can be used for advocacy. I think that that's a connection that most people probably don't make. So I appreciate that. There's a question that came in now, Shannon, I think this might work for you. Who are the key players that need to be at the table to start reducing violence? I mean, I know Tracy kind of touched on that a second ago when she was talking about the different sectors, but I think this participant really wants to get at the core, like who are the folks that must be there on day one to really start addressing this issue?
Right, thanks, Erica. And yes, I agree with Tracy. The business community, the media community, the faith-based community need to absolutely be at the table. Health departments, of course, hospitals, universities, criminal justice, and schools, you know, all need to be present. But most importantly, those that are impacted by violence. And so, you know, we might look at some communities across our country and say, oh, violence is down overall, and when we look at a county-wide ranking, right, we might see that numbers are quote-unquote low, but in pockets within the community where violence is present, it's absolutely important that those that are impacted by the violence have a seat at the table and their voice is heard. I think oftentimes we'll pull together, you know, teams of stakeholders who represent the entire city or who have, you know, the quote-unquote power brokers, the traditional power brokers, but we really need to make sure that those that are understanding violence, those credible messengers like Rashid and the team of interrupters in Kansas City really need to be at the forefront, because for the, you know, we talked about data and the quantitative piece of it all, but the qualitative piece is just as important, because so often in those data sets, you know, we get down to numbers and then people become numbers and we lose those stories. So really important that we make sure that we are authentically inclusive of individuals that are experiencing what we are trying to prevent.
Absolutely. Thank you. We had a participant, actually 2 or 3 participants, wanting to know about opportunities to reduce gun violence. Rashid, can you address that?
Well, Missouri is a gun state, but in terms of gun violence, definitely we have to reach out to our legislators and begin to mobilize to get everybody to understand that this is a public health issue. Violence is a public health issue, and we have to make sure that we're getting the proper funding and the support from our legislators to get this work done. And a lot of times we don't do that. We look at it as a police issue, but it's a public health issue as well. There's a lot of things that we can be doing on the prevention side to stopping a lot of these homicides and shootings that are going on, because there's a lot of indication that people can predict if a child is going to go to the penitentiary based off their education level. So we can predict if they're going to be violent based off their level of trauma and things like that. And there's a lot of things that we can begin to do and employ to prevent that from happening. And we need to attack it just like we attack smoking cessation. like we haven't even given up on that. We're constantly taxing it. We're constantly raising the age limit for it. And the same thing has to happen with violence. We have to constantly legislate around it and make sure that we discourage people from engaging in it and to create a culture of peace in our communities.
Yeah, I like that. And throughout this entire presentation, all three of you have been talking about we really have to change the way we think about violence, and that's key here. I can hear that coming through your response. I have another question that I think that actually a participant actually would like you, Rashid, to answer, and her question is, how did Aim for Peace build relationships with community residents, and what barriers have you guys had to overcome, building those relationships? Great question.
That's a wonderful question. One of the things that we did was we hired people from that community. We didn't bring people from outside. We hired people who were credible messengers, people who are from that community and may have been in that lifestyle before and had changed their life. And so people from that community recognize them when they're walking down the street. There goes Johnny, there goes Saul, whoever that person is. They recognize them and they embrace that person. So we go door to door. We talk to the community residents. We have relationships with our neighborhood groups. We talk to them. We talk to the business owners. They like to see us come around and talk to the people in front of their businesses because it's good business for them. Peace is good business for business people. And so we make that our presence beneficial to the people that's in the community. So one resident comment said, well, Aim for Peace around, there's no shooting. So I like Aim for Peace around all the time. And so I think that's a good look for us, to have that relationship and people know they don't care about what you know, they want to know that you care. And we should demonstrate that every day out there.
Thank you. I know we're running out of time. We are going to have an after class. I want to let all of our participants know that so we can our guests can answer some additional questions. But I do want to get this comment in from Desiree. She just wanted you guys she just wanted to say thank you for all of your dedication and hard work. And usually I know this is time reserved for questions, but I felt that was really nice to let you guys know that.
We definitely appreciate that.
This might be a question for Shannon. This particular participant wants to know where can she find the U.S. map that was shown in the beginning of the webinar that showed the locations of violence intervention efforts. I think that was a map that you showed when you were speaking.
So I'm happy to send that out. My email is skc1 at uic.edu, or Erica, are the slides going to be made available for participants?
Yes, the slides will be available within the next 24 to 48 hours on our website.
But otherwise, that's the only place it lives right now. It's not posted on the website yet.
Okay, I'm going to ask one last question, and then we're going to wrap up, and then we'll go into our after class. I do want to remind participants you are able to use the question box to send in your questions, and if you have time to stick around for the after class. And this is the last question I'll ask before I turn it back over to Mary. Tracy, do you have health education specialists work for your programs?
Yes, we do. And when we think about health education, I think this is where going into the public health 3.0 practice that we're re-envisioning public health education in its broadest sense. So our public health educators are also Aim for Peace workers, but then we also have public health educators that work on the other aspects of social determinants of health. So we do have a broad range. So there are folks who are working on mental health first aid, there are people who are working on inside of schools, inside of community centers, inside of some of our local holding facilities or jails. So there's different ways that we have health education all the way down to nurse-family partnership, to through our communicable disease prevention, so as well as emergency response planning. So we are a full-service health department, and we do provide many various aspects or avenues for our health education.
Thanks, Tracy. And Mary, I'll turn it back over to you. Don't forget to unmute yourself, Mary.
Thank you, Erica. Yes, I did. And so thank you again. As Erica said, I really want to encourage people, if you have additional questions, to go ahead and chat them to us. And I also want to mention that the slides will be on the website, and the entire webinar recorded on the website in the next couple of days. But in the handout section, you can also find the slides there, and there you'll find the map. So I just wanted to circle back to that. So in turning to wrap things up, we just want to remind you to please stay connected to our work and work such as this amazing work in Kansas City. Follow us on Facebook, Twitter, subscribe to our e-newsletter so that you can get the most up-to-date information. And just like with the work in Kansas City and with Cure Violence, there's many contributors and partners who make this work possible. And here's a list of a few of those. And then circling back to our guiding question that we started with in the beginning of this webinar, I'd like you to take a minute to consider what strategies might you consider implementing in your community after hearing these ideas from this webinar to reduce violence and its negative impact on health in your community? So we'd really like to thank you for your attention and your participation. And you can contact us through the email posted on the slide, matchinfo@match.wisc.edu, or call us on the phone number listed. And also want to encourage you to check out our website and the resources there so that you can get support for your work. And we have just, according to my time, just a minute more before we go to the after-class discussion. So I always like to ask, and maybe one of you, Rashid, Shannon, or Tracy, can just comment. Is there something that you didn't get to say that you would like to add as a last-minute thought in terms of encouraging people to do this work?
Shannon, why don't you go ahead and take that one? Okay, so I will just say part of the long-term view, not the end goal, but part of it is to ask Congress for $1 billion to support this work. And so if you could all imagine how different our country would look and how we all would be working to prevent and reduce violence, we invite you to really be part of that discussion. We are designing the framework, trying to lift up all of the best work that's happening across the country. So really want to hear more about what you all are doing and your ideas of what this could look like and how we all essentially can work together, because like I said before, there is enough work to go around in this space, unfortunately, and we are losing far too many lives. So we all play a role here and ultimately can reduce violence drastically if we can figure out a way to come together and leverage our best resources. So, so not so much a missed point necessarily, but an invitation, if you will, to really come work with us. And we have, you know, formal ways that you could sign on to be part of this movement. We'll be meeting at the American Public Health Association conference, and we will have a special session on the movement there as well. So hopefully you all are feeling like you want to be a part of that and start implementing aspects of it locally in your community, and hopefully figure out how we could make the full comprehensive system become a reality.
Thank you, Shannon. And I know that in the list of links, and Erica chatted out the Cure Violence website, so people can get more information there, as well as links to the work in Kansas City. So on that note, we will officially conclude this webinar, and again, I want to thank our guests for their amazing work, and for all of you on the call for your interest and your work in your community. And as we said, that we'll just take a 1-minute pause and then continue in terms of an after-class discussion and answering questions if there are more questions that people haven't had a chance. So thank you very much from County Health Rankings and Roadmaps. So Erica, I am going to turn it back to you, and if we continue for just a few minutes or 15 minutes, do you have other questions that people have asked and would like to hear more from our guests?
Yeah, I do. So thanks to our guests for sticking around for a few minutes. And so we do have some additional questions that have come in. And so one of those questions is, have you seen the correlation between violence decreasing but the prison rate increasing? And if so, where can they find out more information or more statistics around that? So I'm assuming that this caller is saying that they have seen violence decreasing but the prison rate is increasing in their area.
So I don't have specific data on that, but you know, I think that's been a common topic across the country, especially in terms of criminal justice reform. And so I think, you know, one of the big notions here is if we interrupt the spread of violence, we are interrupting those acts that are deemed criminal, which would then lead to a prevention of individuals going into the system. Another aspect to think about in terms of this model is that we are hiring individuals that are coming out of the system who oftentimes are at high risk for going back into the system. And so working with you know, individuals who have been chronically exposed to violence to not only overcome that obstacle, but to become part of the solution. So a reentry effort, if you will. And then lastly, many of our communities are actually working to identify, you know, if there's 10 people who are deemed high risk for being involved with violence, how to make sure that they're directly providing the conflict mediation support, the skills management, and the resource distribution to those individuals so that the violence rate goes down within those individual communities, and then that person doesn't end up back in the system. So it doesn't entirely answer your question, but we are aware of the issue, I would say, and trying to mitigate that through our programs and our models. Tracy or Rashid, you might be able to speak to that further. We don't have any specific research either that points to it. However, I would echo what Shannon is stating in terms of there is a trend that we see, but do we know if the trend is causally related or is it related to some other factors? That's something that probably we need to bear out in further research.
Okay. So this is a question that kind of resonated with me because I live in the Orlando, Florida area, and one of our participants wanted to know, how do you convene people after a mass tragedy like what we saw happen in Orlando earlier this spring? I'm not sure. Shannon, you want to take that? Start with Shannon, maybe.
Can you repeat the question one more time? I just want to make sure I got it.
Okay. So how do we get people to coalesce around the issue of violence following a mass tragedy, like the shooting that happened in the Orlando area where I live at the Pulse nightclub? And you know, obviously, I can't read between the lines with this question, but it did resonate with me because I live just 30 miles from Orlando, and we were so, and still are, impacted by the trauma of this that I think people are just not even sure where to start. So could someone speak to that?
Right. So I would definitely love to hear from Rashid in terms of responses to violent episodes and what the community response is in Kansas City and elsewhere. So for Orlando specifically, you know, I think yes, it not only hurt the Orlando community, but I think it resonated, or it was felt across the country, and if not the entire world. And I think that's happening on, you know, all too often of a scale at this point in terms of mass shootings, if you will. And so one of the aspects that, you know, we talk about is that this is contagious. So when we think about Orlando, when we think about some of the other mass shootings that had happened across the entire country, how it wasn't circumstantial that one was happening soon after another. And so so I think the notion of identifying individuals who are at risk for violence and really working again with all systems, so workplaces and schools and criminal justice and you know, all areas of the community being able to identify if individuals are exhibiting this behavior. And then ultimately the healing, right? So we all are left with these wounds that are exposed. And I'm in Baltimore, and so after our uprising, I think many people were just in this state of shock. And so the aftermath ended up with many healing circles that were put on by individuals that were credentialed in being able to put on healing circles. They were put on in spaces where people already were, as opposed to just inviting people to an additional meeting. Or, you know, we had a trauma line that where people could call if they needed to talk to somebody. But oftentimes, as you know, people don't know that they're going through traumatic events or the aftermath of traumatic. So we found that going to the spaces that people already were, and then building that community, right, to build that resilience, to really start cohesiveness and bonding, so that we could all heal together. But I think talking about it is absolutely important. We talk about that in like cognitive behavioral therapy and others, that having people really who've witnessed trauma and been involved and exposed to trauma, talking about it is important, and then replacing those behaviors with positive ones is very important as well. And knowing that the support is there. And so coming up with action plans where things will be different, that protocols will be in place, that changes have to be made, so that we're not constantly at fear that this is going to happen again.
Yeah.
Rashid, do you want to speak on that a little bit, what that looks like in Kansas City, say after, you know, a weekend, if you had a few shootings or whatnot? Like, I know different circumstances, but I think in terms of just how it's felt within the community, it's very similar.
Yes, and we've experienced several young people being killed. We had an 8 and a 9-year-old killed just a few weeks ago. In the same house and everything. So we've had that, and so it's been an overwhelming grief to that family that we've seen, and a lot of trauma. And I think we underestimate the effects of trauma on us, even watching it from Kansas City all the way to Orlando. We have to definitely begin to treat the trauma that's going on and make sure that we have the right professionals around and integrating trauma-informed care into our systems to make sure that people are properly trained and executed. It should be almost like CPR now, I believe. There's trauma-informed care that everybody should be, you know, have some type of skills to be able to do it, because the trauma and the violence is so great now that we have to begin to deal with it, because what we see now is a lot of people with post-traumatic stress walking around, and then they're also creating victims. And so we've created a program here in Kansas City where we have a trauma network where we're dealing with the pastors, having the pastors visit the family and the communities, and dealing with the male survivors of violence that happen in the community. So I think it's definitely important that we begin to deal with the trauma and healing, and deal with healing after these horrible incidents.
I love Rashid. I just love the way he says it should be almost like CPR, you know, just second nature, something that we're totally trained to do, to recognize when someone is in critical need of an intervention, like you would do when you can recognize that somebody's in need of CPR. I love that. We had one question that is about taking political action, and so the question is, are there any political roadblocks to working on violence from a health framework? Who wants to take that one?
Well, that's what is Aim for Peace and the Cure Violence thing is from a health framework.
Right. I'll let Shannon kind of speak to that first in terms of the work in the space that you're working in, and then we'll comment on it afterwards.
Yeah, so in terms of policy and legislators buying into this, is that kind of the notion that we're getting at here, and whether or not this shift in mindset is
because she did have a follow-up. Yeah, because she had a follow-up question is, you know, how can you overcome roadblocks? So, you know, are there roadblocks and how can you overcome them?
So yes, there are roadblocks. I think we can start there. And I would say, because again, this is our traditional way of thinking about violence, bad people, bad places, lock them up, put them away forever, right? And these are, you know, people that don't quote unquote deserve to be in our community. You've all heard this rhetoric, you've all heard this just pervasiveness of really isolating people who've been involved with violence, and the NAACP former president Ben Jealous said recently that we criminalize entire communities and we victimize other communities, right? And so we're protecting some and criminalizing others, and so this mindset is kind of where we are. And so not to say that the criminal justice system doesn't have a place, because it absolutely does, but health has a place here too, and we really haven't stepped up into this space enough. And so in terms of like thinking through what a policy shift would look like, it would also be, you know, a significant resource shift. And that, you know, as soon as we start talking about money and allocations, nobody wants to necessarily give up what they're using to deploy their resources, when, you know, oftentimes many people, if not all, are working on a shoestring budget, especially in communities that are violent. So it is a challenge. It's in terms of resources, it's in terms of mind shift, it's in terms of redoing policies that have been put into place for generations at this point. And then it's going back as far as, you know, things like segregation of entire communities and segregation of people and resources. And so, you know, when you really start drilling down to those social determinants of health, there's a lot of, you know, work that needs to be done and things that need to be undone. And so, you know, getting to that and thinking about the enormity of the issue and how it all started, you know, really can oftentimes halt people's ability to take action. But as Tracy said before, when violence is present, it is really hard to work on education. It's really hard to work on housing, and not to say that we can't work on those social determinants of health. We have to, but we have to also work on violence right now because people are dying daily. So there has to be the both and approach, and oftentimes people want the either or a clear-cut answer. So it really, you know, often gets complicated. So I'll leave it there. There's many more roadblocks that we could talk about, but Tracy, I'm sure you've, you know, witnessed or have been going through some of them in Kansas City specifically.
Absolutely. In terms of roadblocks, in terms of practical pieces, I think one of the biggest things is a cultural shift even within the way that government approaches, but ultimately look in terms of the way we approach it from a worldview, in terms of how we perceive violence. Oftentimes in our country, our national narrative is built around two different axes of powers of influence. One that's either focused on a nonviolent persuasion, where we're focused on, you know, the values that sometimes are persuaded through our religious or philosophical processes, as well as the normalcy of civilization that comes through the power, influence, access of violent force, meaning through our history, our cultural norms, our political persuasions, our military, industrial, economic complex that really focuses either on a swing of contributive, distributive, and restorative or social justice, or looking at retributive justice and punishment. And as Shannon indicated, when we were looking at things as bad people, bad indicators, as opposed to changing our learning, even to the point of changing our language, one of the things that we have as our national narrative is there's a lot of things that we even focus on that even in our words that we speak sometimes create some of those roadblocks. Like, for instance, we have statements that, like, you're killing me, which means you're too much, or bite the bullet, which means just do it. One of the things that we have to do in terms of looking at roadblocks is maybe not look at them as roadblocks, but look at them as opportunities to persuade to a more nonviolent persuasion. And what I mean by that is, I think if we always constantly look at it as like an us or them, we too in public health will never move as far on any issue. And that's one of our hallmarks of our frameworks, is that we don't look at it from that perspective. We look at it purely in the symptoms of how can we interrupt the transmission, how can we begin to affect those who are actually doing the transmission, and then lastly, how can we change social norms. Same thing in terms of violence prevention, no matter if it's the person who's pulling the trigger on the street or the person who may be creating currently a disadvantage to moving toward positive change in terms of funding for violence prevention, or relaxing rules or structures within a governmental entity so that you can hire people who would non-traditionally be within your structure. So I think it's all about how we look at the public health framework and how we look at our own worldview.
Tracy, thank you, because you actually talked about in your response some system changes that can be made to actually move the needle on this that doesn't necessarily have to involve big P politics, if you will. So I've given those various examples. So this is actually we're at time, guys. I had a feeling we would end up using all of our time in questions, so I appreciate you sticking around. Mary, I'm going to turn it over to you just to close us out, and I want to thank everyone for your questions and comments that were sent in today.
Yes, and thank you, Erica, for being the co-pilot with this, but most importantly, again, to thank Rashid, Tracy, and Shannon for sharing your work and your ideas and your inspiration. And so stay tuned for other webinars and visit those links in terms of for more information. And on that note, we're going to close the webinar. Thank you so much.
Have a good afternoon. Bye-bye, everyone.